So like I said, we're going to talk about invasive ventilation as a just looking at kind of what some of the basics are, why we do things, try and go through some of the acronyms because they don't make a huge amount of sense usually. And kind of do a bit of practical when the nurses ask you for help, what you're looking at basically. So if we go through a bit of physiology initially, if you think about normal breathing, that's with a negative inspiratory pressure of about 5 centimeters of water, which is created by you expanding your rib cage with your intercostal muscles and your diaphragm. So you get about -5 centimeters of water, and then when you breathe out, everything relaxes and that returns to atmospheric pressure, so everything comes back out again. And normally the respiratory rate is controlled by your CO2. So if your CO2 is a bit low, then you'll take some or breathe a bit more rapidly. If it's high, then you'll sorry, other way around. If it's low, then you'll breathe a bit more slowly, a bit less. You can make yourself not generate much need for breathing by deliberately breathing really hard for a while. Just stop for a bit until your CO2 rises again. If you compare that to ventilation, it's completely the opposite. Because it's invasive positive pressure. Instead of creating negative pressure, initially you are pushing air in with positive pressure. And there isn't any way of getting the air out except getting it back. You just reduce the pressure to your expiratory pressure, whatever that might be, and let it just automatically comes out. I said it doesn't happen if there's flow limitation, which we'll talk about a bit later. That doesn't happen very easily in normal breathing if there's flow limitation, that you have to actively coach potentially, which is what asthmatic people do. When you're on sedation and on the ventilator, then you can't actively breathe out, so that becomes more of an issue potentially. And you don't have control of your respiratory rate when you're on the machine, so your CO2 might be a bit too high or might be a bit too low, because the machine does it for you, probably. But it's very unphysiological, basically. ARDS, or acute respiratory distress syndrome, is got quite a complicated definition. It's acute, so it happens within a week of a known problem, and that might be infection, it might be infection of the lungs, it might be septic shock somewhere with another source, as part of this the sepsis kind of syndrome, or it might be something else completely random, or not random, but something else that causes a problem, such as massive blood transfusion or poisoning, or I know they had one at Glenfield last year who'd been struck by lightning that causes ARDS. It's not a common thing, but it can be caused by pretty much anything. So they get, but the requirements they have to have bilateral opacities on the chest imaging. It can't be just one focal bit, that would more pneumonia. And the respiratory failure that's not, they look like they're fluid overloaded potentially in the way that they're ventilating sometimes, but it's not just, it can't just be explained by that, or cardiac failure. And you're supposed to do an echo usually to prove that it's not just heart failure, basically, that's caused the problem. And it's categorized into mild, moderate, and severe, which is what they ask about in exams and stuff. And that's based on PF ratio, which is PaO2 to FiO2. So you work out the blood gas and what their PO2 is, and then you divide it by whatever the FiO2 is. So if their PO2 is 9 and they're 60% oxygen, that would be 9 divided by 0.6, which would end up being quite high. or lower, but it's the definitions are done in millimeters of mercury, which is why you end up with numbers that you can't remember in kilopascals, basically. But that's roughly what they are. We don't calculate it very often in practical terms, but that's why there's bar, bother, and spin. That's what they're talking about. They're your standard monitoring requirements on ICU, regardless of what's wrong with you. Which includes a bedside nurse as an important thing, in the same way that your anaesthetic AAGBI monitoring requirements are the anaesthetist present all of the time, as well as all of the monitors and stuff. Blood gas is the extra one for ITU, or blood gases more regularly anyway. If I talk about ventilator-associated lung injury, which is what we're trying to avoid when we're doing invasive ventilation, but it's really common. People talk about atelector trauma, volume and barotrauma, and biotrauma. So atelector trauma is when you have lots of collapsed atelectatic alveoli that are just flattened, and then you are trying to inflate them, and every time you inflate them, they just flatten back again and then go up, and they don't like all of that. They like to be kept open. They get lots of inflammation, inflammatory mediators and stuff with repeated stretching and squashing. Volutrauma and barotrauma are just, you can't really tell the difference, which is why they're lumped together, but it's high volumes or high pressures that usually go together. And basically you're popping all of the little bubbles and can cause pneumothoraces, that kind of thing. Biotrauma you can get from as a consequence of all of the others, when you get lots of inflammatory mediators released into the alveoli, which then impairs their ability to be useful for gas exchange because they're full of inflammatory sludge. It's more complicated than that, but like simple stuff. It's inflammatory sludge works in my head. So you're trying to. We know that invasive ventilation is unphysiological, but we're trying to minimise the damage that we're doing by these things that cause the biotrauma, which then worsen ARDS and gas exchange and things. That make sense? Okay. So there's a nice CT of what happens when obviously there's some, I think that was a COVID one actually. They've got an underlying lung problem, but you can kind of see where the like atelector trauma and volutrauma and stuff has happened, and there's like almost looks like bubbles of air, which probably aren't actually very functional, and a lot of inflammatory sludge in there as well, which is all the whiteness. So there's not very much of those lungs that's actually going to work for gas exchange because the alveoli are full of crap or they're destroyed. That's what we're trying to avoid. It doesn't always work, clearly, but we're trying. And we try and do that by doing lung protective ventilation, which came from the ARSNet trial, which was kind of beginning of the century. It's been around a long time now. And ARSNet's still going to try and gradually try and work these things out and improve things as much as possible. But the general rules are that you don't go more than tidal volumes of 6 mils per kilo, whatever mode you do. We'll talk about modes in a minute. And it's based on predicted or ideal body weight, which is based on height, not their actual weight. So if somebody's the same, so I'm 5'6", and I weigh 60-ish kilos, my lungs are going to be the same size as somebody who is the same height as me but weighs 150 kilos. You wouldn't want to blast that much more air into that person just because she's bigger, because their lungs are actually going to be the same size. mine roughly, maybe even a bit smaller if they're a bit squished. So yeah, it's based on height rather than and gender, but height rather than actual body weight. And we don't aim for oxygenation too high, because higher oxygen, I think it's I don't know if it's more the amount of oxygen, or if it's just the lack of nitrogen, but they get atelectasis from hyperoxia as well. So don't aim for SATs of 100. You don't need SATs. People normally don't have that. To minimize barotrauma, don't put the plateau pressure higher than 30 as a general rule. And you can increase the PEEP as you go up on the oxygen, which makes sense. I never ventilate people in theatre without any PEEP anyway, because they're not used to that. It's not normal to be breathing through a tube. You would normally have a little bit that you generate yourself. But as they start requiring more oxygen, you need to prevent atelectatic trauma and try and keep those out, whatever alveoli you do manage to recruit, try and keep them open. So this is based on the ARDSNet guideline as to what PEEP they should be on, depending on how much oxygen they're on. And this is older, and we don't tend to go more than about 12. I have tried going higher, and it hasn't made that much difference. So I don't think people normally go more than that, but this is theoretically where this came from. I don't know. I've never worked anywhere that does go like ridiculously high PEEPs like that. Although you could say that that is what APRB is. And then if you can't ventilate them enough so that their CO2 is coming down, so we just call it, we give up and call it permissive hypocapnia, basically. And as long as their pH is okay, we just tolerate the high CO2. So we tolerate a pH of about 7.2. If it starts getting lower than that, it starts causing other problems. But we do try. Does that make sense? So they're the rules. If people talk about exams and lung toxic ventilation and physiology and stuff, that's where it all comes from. It's from the ARDSNet trials earlier in the century. So there's a load of acronyms to do with ventilation. Does anybody, do you know what they are? Does anybody not know what any of them are? Want to shout out one that you don't know? Ramp, yeah.
I don't have a good handle on the intrinsic.
Okay, I'm going to talk about intrinsic PEEP in a minute. Yeah.
ASB, I've never heard.
ASB is relatively simple. I don't know. Yeah, assisted spontaneous breathing. It's the same as pressure support on the newer ventilators that we've got. The annoying thing is that all of these things, these are mostly Draeger ones actually, but all of them are, all of the different makes of ventilator have very similar modes of ventilation, but they all have slightly different names that mean different things, which is annoying. And you have to try and work out how they correspond to each other. I meant to go and look at the ventilator because I can't remember what the modern, what the new one is, what ramp is called on the new one. I forgot. Ramp is the speed of going from expiratory pressure to inspiratory pressure. It's set at 0.2 seconds as a default on our ventilators. It's not called on the newer ones. It's not called ramp. It's called ramp on the old ones. I can't remember what it's now called. If Jenny can, please shout, because I can't remember.
Jenny can't remember either.
Fire off. And yeah, normally 0.2 seconds is fine. If you've got if they've got breathing through a tube, it doesn't seem to matter. If they're breathing spontaneously and are doing it through with a non-invasive mask, if they're finding that difficult to tolerate, the simplest thing that often makes a big difference is if you can increase the ramp speed, or whatever the new one's called, I can't remember. It's in the settings. It's one of the little blue circles that you swivel with on the Dragers. If you increase it to somewhere between half a second and a second, suddenly they go, oh, that's easier. Because if you think about it, you don't breathe in 0.2 of a second. You breathe in over about a second normally. So they're getting hit in the face by air and find it really difficult. If you can slow it down so that all the pressure doesn't hit them all in one go, they find it much easier to tolerate a lot of the time. And it can make it much easier for them to, for the people that wouldn't tolerate a mask, suddenly make it, oh, actually, that's not so bad. It's a very simple thing, but it makes sense if you think about it and understand.
What does the R stand for? Sorry, so I guess it's amplitude.
I don't actually know what it stands for. It might be rate to maximum pressure, or I don't know what it, something. That's what it means. Or it might just be it's a ramp going up. I don't know. Anybody want to ask about any of the others? Okay with the others? Yeah. Okay. So if I go through some of the modes, volume control is, for a start, there's not really much evidence whether one mode is better than the other. Lots of people try and find, nobody's really been able to find any evidence that one is better than the other. And I think it's more of a cultural thing as to what the unit that you happen to be working on is used to doing. Here and at Glenfield, we tend to do BiPAP, a pressure control. In Europe, they do a lot of volume control. I don't think it makes a huge amount of difference, to be honest, but it's what the nurses are used to, which makes your life a lot easier. So volume control, and the difference is the shape of the waveform, which is why I put graphs there for you. So volume control, you set your FiO2 as you would do, however much oxygen you think they need. And then you set your tidal volume as to however big a volume that they need. That should be 6 mils per kilo of ideal body weight ish, which is usually somewhere between 4 and 500 mils. Set their respiratory rate, which should be 14, 16-ish probably. You can vary your inspiration time if you want to. The ventilator option has the defaults, just do it and you can fiddle with it later. And you can set your peak depending on how much oxygen they're needing. And it will do all of that. It will go up in a bit of a slope. If you look at the top graph is pressure against volume. And it will go up gradually and keep going up until it gets to the volume that it wants, that you've set it needs to get to. And then it will drop a little bit and hold it open. So it does mean that it takes a bit longer to get to your maximum volume. And it will have a higher peak pressure than you might want sometimes, because it will go up and then it will drop a bit. The bit that it drops to, which is here, that says P plat, which is plateau pressure. So that's the bit that the evidence is that it causes barotrauma, because that's where it is for longer. This one is your peak inspiratory pressure, which might be higher, but it isn't shown so far to have caused that much of a problem, unless it's ridiculously high. And then this lower one is your flow wave. So gas going into the patient, lots of gas, same amount of gas all the way through, but the pressure increases, and then it comes out in one go, which is your middle wave on the ventilator, usually. Okay. And then, so pressure control, which is BiPAP here, which is bi-level positive airway pressure. You do this a similar thing. You set your oxygen, you set your peak depending on what your oxygen level is, and then you set your inspiratory pressure and your respiratory rate and work out how, and then you have to watch and see how much volume you generate with whatever pressure you've set. You have to guess a bit initially and then watch it for a minute or two and then adjust it as necessary if it's too high or too low. If you look at the waveforms, it generates, it goes from your expiratory pressure and it goes up to your positive pressure. It's a very square waveform, so you don't get the peak in the same way. Your plateau pressure and your peak pressure are the same. And it will stay at that pressure for the whole, whatever inspiratory time you've set it at, or the ventilator's done default to. And the flow wave is a bit different as well. It will go up and then it will hold it open, but less air is going in, and then it will release it all in one go in a similar way the other one does. But you just have to be a bit more, as the patient's compliance changes, you just have to monitor them because their volumes will change. So sometimes we go around on the ward round and notice that their patients breathing it with tidal volumes of 700 because they're more compliant than they were yesterday, but nobody's turned the pressures down. Just have a look when you go and do your daily review. If the pressures are ridiculously high, then if your volumes are ridiculously high, then just turn the pressures down a bit. CPAP modes on our ventilators, like I said, it changes depending on which make of ventilator you've got, as to what they call it. But on ours, it's called CPAP pressure support, which means that the patient is initiating the breathing. We're just helping them with the pressure support, and you can set the peak to whatever you want and oxygen in the same way, and then set them a bit of pressure support depending on how much you think they need. If you're doing it to try and extubate them and come off the vent and they've been on for less than 12 hours, and they're probably not going to need much pressure and aren't going to need to be on a trial period for very long. If you're doing it for a trachea wean and they've been trying for several weeks, then it's going to take doing it by a very small increment for over a very long time. But as a general rule, just have a look at their breathing pattern on the flow trace, which is this one. And if they've got very fast respiratory rate with very small volumes, just increase their pressure support a bit, and see if you can get it to a period where it all slows down and looks a lot more controlled. It's just showing that they need more than the ventilator's giving them. As a general rule, if you haven't noticed, if the flow is grey, then it's a spontaneous breath. If the flow is darker, then it's a mandatory breath. That's what the ventilator thinks it is anyway. If you haven't figured that one out yet. Does that make sense? BiPAP and CPAP. Okay. APRV. I know we've got patients on with APRV at the minute, haven't we, on the unit? So it's completely the opposite to physiological breathing, basically. There's no negative pressure at all. It's continuous high pressure for as long as possible to try and hold the lung open and recruit as many alveoli as possible, and just keep them there. And there are time cycled releases. So you set an inspiratory time and an expiratory time, and you set your high and low pressures. And just see what happens. You are trying to hold it open as long as possible and then let it go for a very, very short period, usually about half a second. And it needs to be short enough of release that your pressure here, this one, doesn't get back to zero, because if it gets back to zero, then you're probably going to get atelectasis again. You're trying to hold it all open. because it's so opposite, you are going to end up with a high CO2 because they're not ventilating, as in they're not getting enough minute ventilation to get CO2 out of them. So if what the ideal thing is to try and get them breathing on top, so they need to be not too opiatized, not too sedated, so that they can breathe. And people seem to find it quite comfortable even when they're awake. And we have had a few recently, the last few weeks, haven't we, that have actually weaned quite well on APRB on the trachea, and have been breathing and rehabbing and stuff over the top of it without it causing that much of a problem. So like I said, spontaneous breathing is required for adequate ventilation to get rid of the CO2. It also helps venous return. If you think about it, you're used to having negative intrathoracic pressure. APRB is obviously mostly positive intrathoracic pressure, which means that the passive blood flow back to your heart at the IVC doesn't happen very well. So you need to try and vary the pressure a little bit to try and help with getting blood flow back to the heart. And yeah, you do need them to be adequately filled. If they're a bit empty, so their venous system is pretty empty, that blood is not going to get back as soon as you put intrathoracic pressure that high. It won't get back to the heart. They won't have enough venous return, and their blood pressure will just go away. So when you first put someone on APRB, just keep an eye on the blood pressure for a couple of minutes, because it will just disappear if you're not careful. And if that happens, put them back on whatever they were on before and give them some fluid first, and then do it if you want.
Is there a risk of gastropathy with that?
Yeah. Yeah, so I've got some little graphs. Like I said, it does improve alveolar recruitment and try and open things out and increase your FRC. And try and reduce all of the strain and various biotraumas and stuff. It does cause problems. Like I said, it can cause significant hypotension. If your T-low's too long, then it will cause little bits of collapse that you've not seen. And it can get all sorts of weird pressures, and a lot of it's because your lungs aren't very healthy, and that's why you're needing to do it in the first place. So, like I said, there are risks, there are problems that you can't necessarily fix, but I kind of talked about the cardiovascular ones. There's my graph. I knew I had a graph somewhere. So like the other one, you set your FiO2 for what you need. You set your P high, which will probably be somewhere between 20 and 30 initially, and look at, it will give you volumes, and just look at those. If you can go up or down depending on whether they're really high. Your P low is normally 0. Sometimes you might put it a little bit up, but normally we just put it on 0 just through convention. And your T high will be somewhere between 3 and 6 seconds. I always start on 4. I don't know why, but I always start on 4. With a T high of 28, I guess. And then your T low of about 0.5, and just see. It's called slope. Ramp is called slope on the new one, on the new vent. You can reduce it in APRB because you don't have to do it in the same way you're going suddenly from nothing to full. You wanted to get it there as soon as possible. And that, yeah, like I said, try and make sure that there is some spontaneous ventilation. Like that one. So you can see that there's the little grey bits suggesting that they are breathing on top. That's what you want it to look like. And you want, for this bit, you want to make sure that this is not getting back to 0. There's always a bit of blue above the graph. That's what you're aiming for. How you tell how long a low time you want is based on your flow chart, which is what this is expanded. You want it to get to about 75% of peak. It will go drift down, and then as the inspiratory time comes, it will suddenly disappear. You want that angle there to be about 75%. So that one's a bit too long. You want it to look like that. And you can sit and watch and adjust it depending on how the patient's behaving. Or the newer ventilators do actually have a T-low termination setting, and then you can adjust the percentage of, so you will set it at 75% and it will adjust it depending on what the patient's doing. And you can set it to a maximum if you want, but you can do it as well. Does that make sense? I know APRV is really confusing and people find it very weird.
I just want to ask about an ELO. It seems like it would make sense to set it at 5, so they've always got people at 5. But I don't know why I don't know if there's a reason. Something like this, or just learn to do it. That's fine.
I've just learned to do it with 0. I don't know the actual answer to that. I've just always been taught to do it that way. I think a lot of the reason is that you're doing it in people who have got severe ARDS generally and have very poorly compliant lungs, and you're usually doing it because you need to recruit them and can't generate any volume. So you're trying to get them as big a difference as possible. If you're doing BiPAP on decent PEEP and you're doing 30/10, actually you've got a driving pressure of only 20, which is the difference between the two, which isn't actually that much necessarily to be able to generate particularly big volumes. I think it's probably to do with that. A good thing to read about APRV, Kaz Sampson, who's one of the Glenfield consultants, did a BJA education article about APRV a few years ago, and it's really well written and makes it make sense. So it's worth reading that if you want. Okay, so that's your comparison of the modes: volume versus pressure versus APRV versus pressure support. And again, that's a bit of an FRCA thing as to whether it's initiated by, they're generally initiated by time. The pressure support mode is initiated by the patient, so they get a bit of negative flow on the thing, it senses that and will give a bit of pressure. The volume control, how much it gives is limited usually on most of the modes by how much pressure you give. Volume control, it will theoretically give quite a high volume, quite a high pressure until you get to the volume it's set, but they do have a maximum pressure as well. And then you can get pressure regulated volume control modes as well, which do a bit of both. And how you switch between in and out is what cycling means. And most of them are set by time, apart from the pressure support mode, which, like I said, is set by the flow, the change in the flow as the patient breathes in and out. If that makes sense. So you asked about intrinsic PEEP. It's what you generate yourself to hold your lungs open, basically. And you can measure it by doing an expiratory hold, which is in the diagnostic bit of the ventilator, if you go into the menus. And it will come up with a number for you by generating it, by doing just doing a hold and seeing what pressure you get to. When they have really rubbishy lungs because of ARDS or fluid or whatever, then they do tend to generate a bit more intrinsic PEEP anyway. If somebody's got severe bronchospasm, it can be a lot more because their bronchi have constricted and aren't letting the gas out. And yeah, that's when you can get breath sucking. When you get gradually, you get more and more intrathoracic volume of pressures, You get very small tidal volumes. They eventually get hypoxic, and eventually their intrathoracic pressure gets high enough that they can't get blood flow to the heart, and eventually they will arrest. And that's how asthmatics often get it. It might be combined with a tension pneumothorax, but it can be a problem. No, sorry, that's what the expiratory breath hold does. It will ignore what the machine PEEP is doing and just see what the pressures do, and just leave it for a while until it stabilizes, and then come up with an answer for you as to what their intrinsic PEEP is. And I talked about gas trapping, or you mentioned gas trapping, but if this is your equivalent of the middle waveform on the ventilator, so your flow rate, normally you want your inspiratory, expiratory flow to get back to 0 before they breathe in again. But when gas trapping happening, it's not getting back to 0, so you can see that there is a volume there, and if you keep going, it is going to just get more and more. So if it looks like that, you need to give them more expiratory time. However you do that, but they need more expiratory time to be able to get their all of the gas that's in them out. Otherwise, you're just going to gradually increase the amount of gas that's in their chest. And you can increase in expiratory time by reducing respiratory rate, or reducing the inspiratory time. So sometimes people, if patients' CO2 is increasing, they'll just increase this respiratory rate and keep going up. And when you get to like 22, 24 on the ventilators, their expiratory time is so short that actually they can't breathe out enough to be able to get the CO2 down. So if you reduce the respiratory rate and just shorten the inspiratory time, that usually fixes the problem. In people with asthma or COPD who've got severe bronchospasm, it looks like this anyway, and sometimes you end up with really slow respiratory rates to try and get them in a safe bit. And I've intubated, I don't know, 5 or 6 asthmatics in my career. It's one of the scariest things we do, because they're struggling with life-threatening asthma before you put their tube in, but as soon as you intubate them and paralyze them, they are going to lose all of their active expiration, so they aren't able to force the air out anymore, and you haven't got a way of getting the air out except disconnecting the tube and leaning on their chest, which sometimes you have to do. But the first one I ever did was as an SHO in Kettering in theatre recovery, because they hadn't got any beds left on ITU, and she was younger than me, and I thought she was going to die for quite a long time. It was very unpleasant. It's scary and difficult to deal with, and that's why if we can't get control of it, that's why we ring the ECMO people, because when you're on ECMO, you really don't need your lungs to work, so you can just wait for the bronchospasm to settle with treatment, and then in a couple of days they'll be off ECMO and absolutely fine. Otherwise they might have died.
It was like you give a few breaths, and every few breaths disconnects from the chest.
Yeah, that's terrifying. They end up really acidotic and really tachycardic because they've had loads of salbutamol by then anyway, which gives them a really high lactate. And all you get the nurses do a gas and then bring you it, and you go, I don't know how to fix it. And you give them all of the drugs you can think of. It's very unpleasant. Okay, so yeah, like I said, things that you can cause higher intrinsic PEEP. Talked about bronchospasm. The quickest and easiest to fix are if the tube's a bit kinked, or the HME filter is full of water. Just it makes you look really stupid. But if you get them to change, just say, when did you last change it? Can we change it? And just see. Sometimes it makes all of the numbers look so much better, and then it's nice and easy to fix. And yeah, secretions and stuff. Emphysema in a similar way to bronchospasm, but it's kind of just the lungs aren't very elastic and that doesn't work as well. And like I said, if there isn't enough expiratory time, because people have just increased the respiratory rate a lot, then that will happen. To try and treat whatever the problem is, work out whatever the problem is, with nebs or suctioning or changing the filter or whatever it might be, increase the expiratory time. Reducing the tidal volume will work a bit as well. And the extrinsic PEEP is the PEEP that the ventilator generates. The intrinsic PEEP is the PEEP that the patient generates. You can have no extrinsic PEEP. Sometimes that helps. Or some people say you should set the extrinsic PEEP to match the intrinsic PEEP. I would say try one. If it doesn't work, try the other. You can't. There doesn't seem to be a rule that works for everybody. Just try something and see if it works. If it doesn't, then try something else. And yeah, if you can't fix it any other way, then yeah, disconnect them from the tube and lean on their chest. If you don't really want, this is when you can get tension pneumothoraces, which just makes life a whole lot harder. And try and avoid it if you can. Does that make sense? Okay. Weaning, you could have a whole session on weaning, and nobody knows the answer. It's a general rule, but we try and do it. The nurses will reduce the FiO2, usually depending on what the gases and the SATs say. When you're doing your daily review in the morning, look at what's happened with gas exchange and what we've done with the ventilators over 4 hours. Try and reduce the pressures if you can. Try and get the patient doing a bit more, basically, so that they're using their own muscles. Try them on a spontaneous mode if there's no reason not to, and just see if they can do that, even if they only do it for a little while. If they're using their own muscles, then they will lose less muscle mass during their ITU stay, theoretically. Just keep trying it. Just like the first time, try it again a few hours later. Theoretically, they should be on less oxygen with a lower PEEP and be able to breathe for themselves a bit and be fairly stable. The way to do spontaneous breathing trial, if you read the books, is take them off the ventilator. We usually do the pressure support 10 to 5/5 generally, rather than disconnect them from the ventilator and put them on bags and stuff. But it's sort of similar to what we're doing when we're doing trachea mask weaning. And just watch and see what they're doing. I put aim for 2 hours on there. I can't remember why. It depends on what the problem or how long they've been on the ventilator and what the problem is as to how long you're going to try for, probably initially. If they've only been on the ventilator since yesterday and actually the problem wasn't the lungs though, post-op or something, then you wouldn't wait for 2 hours before you take the tube out. If they're on APRV and you're weaning them, the first thing to do is try and get their FiO2 less than 0.5. Don't change anything else for a while. And then start to reduce the high pressure when you've got your oxygen down. We call it drop and stretch. So you drop the high pressure and increase the high time. So gradually you can keep going and you drop the pressure. You can do it. You can keep going for as long until they're on nothing. You can get them to a high pressure of 10 and a T high, so 10, they'll be on 10 seconds at a time, which is almost CPAP, basically. Because they'll be breathing spontaneously on top of that. And then you can put them on CPAP pressure support if you want to. Or you can just leave them on APRV like we did for the lady that was in Basie in the last few weeks. The advantage of a trachea is that you can wean gradually over several weeks, and it avoids the side effects of sedatives and lets them rehab a bit, basically, with the other therapists, and you can change what works and what doesn't, and let them have proper day-night cycles and help with delirium. So and let them talk as well. That's really important. So when they've got a trachea, they can't make themselves talk, and I think it's very isolating. So yeah, we do try and let them talk and get them on the can. And put downsize versus decannulate. Decannulate just means take the trachea out. Sometimes we just do that. Sometimes we downsize them to make the trachea smaller and give them a bit longer. Sometimes it might be that because if the trachea is too big, you can't get airflow past the trachea and through the vocal cords, so they can't talk. So if you make it smaller, then they can still get air in and out, but the air can also get past the trachea to go through the vocal cords, so they can have voice again. That'd be quite helpful, particularly if they're probably having difficulty with secretion management. If they aren't or don't have an effective cough, they won't be able to clear their own gunk, so they still need the trachea for clearing out the gunk, but they need less ventilatory support, and they would like to be able to talk. It can be useful to downsize them instead. Okay, does that make sense? Okay, I've got a couple of quick slides on what to do for when the nurses ask for help. Generally, it's go and look at the patient and try and figure it out. And is it an acute problem or is it a gradual thing? If it's an acute thing, particularly, what's just happened? What has somebody done that's changed? Usually they've rolled the patient and something's happened, or physio have just been attacking them. Their breathing's not as good as it was. Or they've got a fever. Is there anything, have they had a chest x-ray recently that we can look at? Did they have one this morning that was fine and when they were okay? Or is there something that nobody's noticed yet? So if they're hypoxic, the quickest thing to do is turn up the FiO2. That will make it all a bit better and give you a bit of time to figure out why they're hypoxic and what you're going to do about it. Then go back to your ABC. Either start at the ventilator or start at the patient. Go along the tubing and make sure that it's all open, it's all working. The ventilator, filter's not blocked. There's not gunk down there. The CO2's working. The tube's still in the patient, or in the right bit of the patient. Have a listen to their chest, see whether they're wheezy or sounds like there's gunk in the way. Are they actually hypoxic, or has their blood pressure gone away so their SATs aren't reading anymore? That kind of thing. And are they actually not breathing enough because they're too sedated or because they're not very well? So treat whatever the reversible bits are, whatever you found when you've done your ABC. It still works, and it might not be as part of your ALS currently, but it does still work, ABC. And work out if they need another chest x-ray, if it's changed from whenever they had a last one. That makes sense? Okay. If you can't find an easily reversible cause, then sometimes they need some recruitment, and there's different ways of doing it. One is to increase the PEEP gradually and just give time. It will take several hours. But you can increase it a bit, see whether it's made a difference. If it hasn't, you don't need to have a lot of patience for that. A quicker way of doing it is to do an inspiratory hold, which is it's on the right hand side as a button on the new ventilators. You just hold it down, and it will tell you how many seconds you've been holding it down. It is worth telling the nurses that you're doing it, because the monitor will start beeping that they're not breathing at you. the CO2 is not going anymore. Get all twitchy. So just warn them that you're doing it. But you can do, if you do 30 centimeters of water for 30 seconds, that's a decent inspiratory hold and will hopefully work as a recruitment maneuver. And you can do that, well, you can do it anyway, but it's a useful thing to do after they've had some chest physio or some suctioning to try and, if you've just suctioned them, you've suctioned out their FRC. Well, try and recruit that. On the chest physio, yeah, they're trying to get all of the gunk out, but they do lots of suctioning and in the process of the beating, so it's worth recruiting afterwards potentially. Or after you've done a bronchoscopy, again, you've suctioned out lots of gas and made it all collapse while you're suctioning out, hopefully therapeutically suctioning gunk, but you might get out, reduce their FRC as well. So lots of recruitment is useful. And then the next thing to do, if we've tried the more simple thing, was proning. Have you done proning yet? Yeah. You probably will at some point while you're with, but it's helpful. We have a little protocol, so and everybody knows which bits. And you kind of do it as a team. As long as you do it with people that have done it before, then it makes life easier. You can probably just follow them, disconnect everything, roll them over, but it changes their VQ mismatching, and hopefully improves their oxygen requirement. And it can do it quite dramatically. You can go from 100% to 40% overnight. Potentially, they should be prone for between 12 and 16 hours. It's one of the few things that we do actually have evidence for. I've got to put that on there. This is about looking at PEEP. This one. This is on the views on the ventilator. You can tell it to look at loops, and this is looking at pressure versus volume. And how you can decide if you need more PEEP basically is look at this one. If you are increasing pressure, and the volume's going straight up like it is there, then you probably don't need more PEEP. There we go. If it's going straight up, then you don't need more PEEP. If the volume's not increasing because it's not coming up away from the axis, then you probably do need more PEEP. It goes along and then up. If you increase the PEEP, then hopefully it will go straight up, which is another way that you can do to look at it. It's in the loops bit of the ventilator screen. You just have to play with them and press all the buttons basically until you find it. No, I did that already. Oh yeah, that's where the manual inspiratory hold button is on the vent. It's at the bottom. Yeah. You can repeat it if you want to do it a couple of times and then see. Yeah, proning is one of the few things that we actually have evidence for that we do on ITU. You look at the ProSiva trial from, I don't actually know, a long time ago, 10, 12 years ago, at least. Okay, if they're hypoxic and they're on APRV, then go up, reduce whatever wheeling they've had on before, increase their P high, and potentially adjust their T high, and then increase their FiO2 just to try and increase and improve it again, basically. Okay, hypercapnia. So if they've got if the nurse calls you because they've got a high CO2, you need to work out whether that is because they've got a high production of CO2 because they're very metabolic for whatever reason, or because they have inadequate ventilation, so not breathing it out, or often on here a bit of both. And again, go back to ABC, just check whether there's any problems with any blockages with the tube or the lungs that you can easily fix. See if they're wheezy. Like I said, see if they're hypermetabolic, so if they might be very tachycardic, potentially hypertensive as well, or seizing potentially, or very pyrexial, that kind of thing. Like I said before, you can do permissive hypercapnia. So is it something you actually need to fix, or are we going to tolerate it? Can you ventilate them a bit more? Like I said earlier about increasing respiratory rate, but beware of doing that too much because you will reduce the expiratory time they have, which can reduce CO2 clearance and be problematic. Or is it gas trapping, like we were talking about before? What you do about it, like I said, you can tolerate it. Maybe it makes the nurses sad, but you can tolerate it. You can, if it's say for APRV, particularly, you want to get them to breathe spontaneously, so try and encourage that. ATC is automatic tube compensation. So the ventilators, if you tell the ventilator what type of tube and what size it is, the ventilators will give a little bit of extra pressure to overcome the narrowness and length of the tube. So you can make sure that that's set properly on the ventilator. And you can reduce T-high to try and if you increase the amount of those breath releases, then you will get more CO2 clearance, regardless of how much they're breathing. If that makes sense. And then look for gunk in the circuit, and you can increase P-high if they're on APRV. Yeah. Okay. Dysynchrony. People say they're not syncing with the vent. The nurses get very upset about this. It's either they're too awake or too asleep for whatever mode they're using. And it might be because they're in pain or agitated, they might be delirious, they might be not too awake because they're very acidotic, so that's increasing their acid, increasing their respiratory drive to try and compensate for their metabolic acidosis. You can just try different modes until you find one that works. Basically, try them on CPAP pressure support, try them on APRV. If the BiPAP's not working, then you can just try something else until one that is comfortable for them and is working. When the nurses say they're not syncing with the ventilator when they're on CPAP pressure support, you can't not synchronize with that. It isn't a mandatory mode, it is going. They might need more pressure support than they're getting on CPAP, but they can't not synchronize. There's something else that's a problem. You can increase or decrease the sedation. Sometimes you get people who are not syncing because they're opiatized, so they're thinking that they need to breathe really long and really slow, big breaths, and so they're breathing out for a really long time, and the ventilator's trying to get air in, but they're breathing out and they're not letting it in, so it alarms at you saying high inspiratory pressure, but high airway pressures, but it's because the patient is breathing out. And in that case, stopping their morphine might be the thing to do to try and reduce the opiates on board. Deep sedation and/or paralysis are a kind of last resort, and they will. I mean, if they're paralyzed, they can't not synchronize with the ventilator because their muscles don't work anymore. And sometimes you have to do that to get gas into them, but it's not a long-term solution, and they will have, the risk is that they will have more muscle weakness and ICU acquired weakness and need more rehab and have longer stay. They're needing muscle paralysis, basically. This is why we don't do it if we don't have to. Okay. If you see that as a ventilator screen, what would you do? Would you say that's okay? I know you can't read the numbers because it's a bit fuzzy, but it's on 21% with an inspiratory pressure of 20, respiratory rate of 8, and a pressure support of 5. Does it seem okay?
It's a mandatory mode.
Yeah.
It looks like the patient's trying to breathe on top of it.
Yeah.
So could you switch to the spontaneous mode?
You could?
To support the patient's breaths.
Yeah. Yeah, you could switch to a spontaneous mode, or even if you'd left them on that mode, I would increase their pressure support as the first thing I did, because it's so, the little grey ones are so much smaller than the big blue ones. It's not effective because they're it's not able to generate a bigger volume. So if you increase their pressure support, yeah, they're probably breathing enough actually to be able to tolerate to be on a spontaneous mode as well. But I think they need more pressure, is what I would do with that one. Yeah, I only have one, I think. Okay, so that was a bit of the basics of ventilation and how it's very unphysiological. We try and do it for a short period as we can and get them breathing spontaneously so that they don't lose all of their muscle mass. Most of what we do is trying to be common sense, and I know it sounds clever, but it's fairly simple a lot of the time. And hopefully there's some practical bits so that ABC is still the most useful in the monitoring. Is that okay? Any questions at all? I like that one. I thought that was a good cartoon. It's the most important button, the shush I'm thinking button. Silence button is the first one you find. It's the yellow one.
Good afternoon, everyone. My name is Mohammed. I'm one of the ICM registrars. Recently rejoined Glenfield as an ECMO fellow. I'm just going to present BLING-III trial. Apologies in advance if anyone heard that before. I understand that it's been presented a few months ago. Right, so sepsis has been always like a hot topic for research and lots of questions about it because how important it is and how frequently we see septic patient in ICU and the significant mortality that comes with it as well. So to answer a few of these questions, we don't know much, or there's not strong evidence about lots of things in terms of sepsis. So there's lots of recent and ongoing trials to answer a few of the questions. What type of fluid, how much fluid should we give? And this is like classic Clovers and septic trial, which is ongoing at the moment. Whether vitamin C and thiamine is important or helpful in sepsis. And this is like LOVIT trial in 2022 and LOVIT COVID in 2023. The role of beta blockers in septic patient, stress L, and this is 23 published. Vasopressors, what type, what kind, and how much, Vanish and 65 trials. The role of steroids, EMAP-CAP, and there's a new meta-analysis in 2023, and Cape Cod, which is being done 2023 as well. And more advanced precision medicine and the role of molecular medicine in terms of sepsis, IMPACT, and PANTHER, which is upcoming trials. So apparently lots of things that's yet to be answered in terms of sepsis. And we cannot mention sepsis without talking about antibiotics. In terms of antibiotics to perform the bactericidal effect, they follow main two patterns. It's either concentration dependent, which mainly depend on the highest peak above the MIC, the antibiotic level reaching the plasma to exert its killing effect. Other type of antibiotics is time dependent, which basically depend on how long the concentration in the plasma will be above the MIC, or minimum inhibitory concentration of the bacteria to exert the killing. Beta-lactams are following time-dependent killing, which means that they need to stay for as long as possible above the minimum inhibitory concentration of the bacteria to exert the most killing. So the background of the study, that beta-lactam follows the time-dependent bactericidal effect. And theoretically speaking, if we manage to get the beta-lactam levels in the blood above the MIC for as long as we can, this might improve the outcome or improve the bacterial killing. In addition to that, septic patients do not usually follow straight line because even normal antibiotics may have normal or unusual metabolism due to increased cardiac output because of the hyperdynamic circulation, which can increase the clearance of the drug, and the capillary leak that comes with sepsis as well. So all of that can contribute to underdosing of the antibiotics. This diagram shows the difference theoretically between intermittent extended infusion or continuous infusions. So this line there is the MIC. So if you give intermittent dosing, which we usually do for most antibiotics, they will follow high peak and then go down. And this is the time above the MIC that they will stay. If you give extended infusion, like over a couple of hours or so, so the time above the MIC will be a little bit longer. And theoretically speaking, if you give extended or continuous infusion, the time of above the MIC will be much, much longer. So if we can prove that continuous infusion can stay above MIC for longer, this may lead to further studies. So that's what led the Australians in 2013 to start the BLING-III, which is a small pilot study, included very few number of patients, and they compared the continuous infusion versus the intermittent dosing, which showed that the main outcome of that showed that continuous infusion have higher plasma antibiotic concentration compared to intermittent dosing. It shows that maybe improvement in clinical cure, but the number of the study didn't allow to consider that as a change in practice. But definitely the higher plasma concentration led to further studies. And then the same team did BLING-II in 2015, which is quite larger study, multi-center, blinded, and they compared continuous infusion versus intermittent dosing for beta-lactams. And the outcome was no difference in the outcome. And then came MERCY trial in 2023, which studied similar thing about just meropenem, which is one of the beta-lactam antibiotics, to determine whether continuous infusion versus intermittent will have any benefit, and didn't show any, well, it showed non-significant, non-statistically significant improvement in outcome. So basically, continuous infusion doesn't improve the outcome. Followed that's a huge, massive trial published in 2024, which is BLING-III. So again, studies the same thing, continuous versus intermittent infusion of beta-lactam antibiotics. The clinical question to be answered: in critically ill patient with presumed sepsis, does continuous antibiotic infusion improve the 90-day mortality compared to the intermittent one? So it's been randomized trial, or the randomization 1-to-1 according to electronic system. It was open label, so both patients and the doctors and the care provider know which arm the patient was randomized to. And the power calculation that needed to be recruited was calculated based on the previous trial, which is BLING-II, and they assumed that 7,000 patients is required to get strong outcomes. And then in the design, they have adjusted analysis, which has been pre-made before the study started, accounting for sex, Apache score, where the patient has been admitted from, and the type of beta-lactam antibiotic, whether it's meropenem or tazocin. And there were predefined subgroups as well to be studied later, which is pulmonary infection patients, according to the type of beta-lactam antibiotic, whether the age is above or less than 65, and Apache score more or less than 25. So these are subgroups to be studied at the end, or sub-analyzed at the end. And they defined clinical cure as an outcome, and they defined clinical cure as completion of beta-lactam antibiotics in 14 days, within 14 days, without recommencing or restarting it within 48 hours after cessation for the same episode of sepsis. And they had a quality check, which is internal and external independent quality check conducted at midpoint, just to make sure the study is up to the desired quality. It's a huge study, 104 intensive care units, 7 different countries, including New Zealand, Australia, Belgium, France, and UK. And the recruitment period were about 5 years, from 2018 to 2023. Has been delayed a little bit because of COVID, but continued afterwards. They included adults with documented or suspected site of infection with a strong suspicion. They have to have had at least one organ dysfunction within the previous 24 hours. And they have to start tazocin or meropenem within the last 24 hours. And they're expected to stay at least 1 calendar day after recruitment in intensive care. They excluded anyone who had these antibiotics more than 24 hours, any pregnant patient, any patient with allergic to beta-lactams, which is understandable, any patient who needed renal replacement therapy, whether chronic or acute, at the time of recruitment, and any patient who's previously enrolled or in end-of-life or palliative care or expected to die soon. They approached 29,000 patients, excluded 21,000 out of them, and randomized 7,200, which is around the number they wanted to start with. Almost half of them were in each group. The baseline characteristic between both groups are very similar. If you can see the age, the sex, Apache score, vasopressors, where they got admitted from, and where's the site of infection. There's no huge difference between them to affect the results, which made the studies quite strong. So in the intervention group, they got continuous infusion of beta-lactam antibiotics, which means like continuous over 24 hours. And they always start with a bolus. So both groups will have a bolus initially, and then the continuous group will have continuous infusion afterwards. They didn't intervene in the duration of antibiotics. So the antibiotics duration was decided by the clinician as normal. And every patient, so they have to be stopped either by clinician or on ICU discharge. So when they got discharged from ICU, they all revert to normal intermittent dosing. And the outcome of that analysis of that group, usually they got duration a median of 5.8 days. And the cumulative dose was around 72 grams for tazocin and 17 grams of meropenem. On the other hand, in control group, they had beta-lactam antibiotics as usual, intermittent dosing, and the duration was clinician prescribed and clinician stopped as well. And the analysis was quite similar to the other groups. So they have almost similar duration, 5.7 days median, and almost similar doses as well. So 70.8 grams for tazocin and 16 grams for meropenem. So there's lots of similarities or comparability between both groups. Both groups had dose of daily dose usually is 14 grams of tazocin, which almost similar to 4.5 grams TDS, which we usually prescribe, or 3 grams per meropenem or 1 gram TDS. And this can be modified according to changes like changing in creatinine or GFR or creatinine clearance. Both groups have been permitted to switch between both antibiotics as long as they stay or remain in the same arm, which means if patient needs to escalate or downscalate from tazocin to meropenem, he can do that as long as he stayed within the same group. All patients will revert to intermittent dosing, either on 14 days or on ICU discharge. And other management will be the same, so no intervention, any other management. So the primary outcome, which was 90-day mortality between both groups, it didn't show significant statistical difference. But when they did the adjusted analysis, you may argue there is a little bit of preference towards the continuous infusion group. but this wasn't statistically different on all-cause mortality. However, interestingly, on the secondary outcome, there is a huge difference between both groups in clinical cure at 14 days towards or favoring the continuous infusion. So the continuous infusion had markedly improved clinical cure at 14 days as defined before. And on tertiary outcome, there's no strong difference between both of them. Studying both groups in terms of side effects that happened in between both groups, there are 10 side effects. 10 patients had side effects in the continuous infusion group and 6 on the intermittent group. However, only one serious or fatal adverse event happened on the continuous infusion group, which the patient had meropenem, had severe encephalopathy as a result of it, and reduced GCS, aspirated, intubated, had a cardiac arrest, and dead. And on studying this patient, they thought it might be meropenem related because encephalopathy might be a side effect of meropenem, and because he had the continuous infusion group, or he had the continuous infusion, this led to high concentration of meropenem in the brain, so this may have contributed to his death. And then this is subgroup analysis mortality at 90 days. As I said, it's not statistically significant difference, but studying in the sub-analysis of subgroups, you may argue it all favors the continuous infusion. And the author's conclusion, they have written that despite this is not meeting statistically significant difference in terms of mortality, but the confidence interval may say that they may be a potential benefit of the continuous infusion. The study strength, that's extremely large study, has been done on multi-center, multinational study, robust internal and external validity, with large number of cases, large number of clarification and quality checks. There are detailed collection of infection site and antimicrobial data, even for the patient who has been approached and excluded from the start, why they have been excluded, and there was minimal loss of the follow-up. On the other hand, it was open label, so everyone was aware which group the patient was, so it's unblinded. And all patients had to go back to intermittent dosing after leaving ICU or in 14 days, which tells you there might be bias in patients who's had like 2 days of ICU and then after that they went to the ward and got better. They still count as continuous infusion. The definition of clinical cure, there's no consensus on that, and they defined it as stopping antibiotic within 14 days without restarting it within 48 hours after stopping it, which you may argue this is not a very strong definition and can have some bias as well. Organ dysfunction, they included patient with presumed sepsis as well. So you may presume that the patient has sepsis and had organ dysfunction for any other reason, had antibiotics and got better, but he never had sepsis and start with. So these patients been included, but you can argue these were in both groups. There's no dose monitoring or sensitivity or susceptibility in this study. However, it happened in BLING-III, and we know that the continuous infusion carries higher plasma level compared to the intermittent dosing. Almost third patient had protocol violation, and it's largely related to delayed dosing by more than 1 hour or stopping the continuous infusion for a bit due to going this transfer, losing the line, scans, and all of that. This trial has been conducted in a context of high-income ICU settings, so it's quite difficult or hard to generalize that on countries with low income or low resources. And multi-antibiotics regimen can be intervening if the patient on tazocin and vancomycin, he may got better because of the vancomycin, not because of the tazocin. And then after that, there was a systematic review and meta-analysis has been done to study the same thing, which included loss of studies, included some of the ones that we spoke about, and shows significantly improving the mortality and the outcome that favors prolonged infusion compared to intermittent infusions. So all-cause mortality in 90 days, ICU mortality and clinical cure all were better in the prolonged or continuous infusion groups. And that's it for me. The question, should it change your practice, given the data that we had? Few ICUs already started to use that. Few ICUs are a bit reluctant, so I would like to hear from you what the challenges might be, and would that be enough to change the practice or not?
Anybody want to change?
Seems to be easier.
We've not done it here yet, no. Can anybody see any practical problems with doing it as a continuous infusion? The nurses would have to get used to it, but
That's intensive.
It was mentioned in the next couple of weeks. I was listening to one of the main TV study.
principal investigator. Yeah.
Yes, so she's a clinical pharmacist. What she said is, if you're doing intermittent infusion, you have to do it with one setting up one infusion takes about 20 minutes. So if you have to do 4 times, that's going to take about 1 to 1.5 hours. But if you set continuous infusion, just 20 minutes, and then it's there for 24 hours, it saves time. So labor-wise, it's more.
Yeah, theoretically, it's less work for the nurses if you do continuous infusion. Does it cause a problem for us, do you think, if it's continuous? Access is the biggest one that I've been able to think of.
24 hours.
Yeah, it's using up one line that they're not going to be able to use, and the nurses never have enough lines as it is. They always want more access. So yeah, not having enough access is potential.
What was the treatment effect? And I missed the actual effect was.
In the initial trial, it didn't show any. It wasn't statistically significant. There was a trend towards reduced mortality and reduced ITU and hospital length of stay and duration of organ support and stuff. I can't remember what the numbers are, but it was.
Kind of interesting meta-analysis.
Yeah, the meta-analysis and the Bayesian analysis that have been done both suggest that there is much better effect, and it is supposed to be statistically significant, I think, on the meta-analysis, wasn't it?
Yeah.
Other thing was that I just said that there was concerns on those statisticians sort of arguing about, because adjusted analysis that should be used to get the primary outcome, because there's baseline difference in baseline characteristics.
Yeah.
So you have to consider them, and then the adjusted analysis should be in that which you should use to make the ultimate outcome. But in this study, they use the unadjusted analysis to get the outcome, and after adjusted analysis, they have a significant difference in mortality as well.
Yeah, I think we probably should, to be honest.
On application on, for example, according to the clear convenience.
Yeah.
So the same dosage
You might need to
materials
change it for that.
should be changed. Measure the levels, serum levels.
Yeah, really demonstrating much harm from it, and it's probably surprisingly, it's better back compounds. It's not going to have treatment effects, and it seems to actually perform trials to show something.
Yeah, and actually, intensive care is quite good, and we're going to blow my own trumpet, but we are quite good at stuff, and a lot of the trials don't show huge effects. If you know anything about British cycling in the last 10-15 years, they were David Brailsford used to talk about marginal gains a lot, and that might be a way of kind of thinking about it. We can try and make lots of little bits a little tiny bit better, then it might make the sum of the whole a bit better.
We're struggling to hear most of the audience, but just one of the challenges that has been mentioned in this study is the stability of the infusion of especially meropenem. So there's different patches across the trusts, and they have different stabilities in the infusion. The one, for example, in Nottingham is just stable for 3 hours. so they won't be able to do that in normal dosing unless there's like CNS dose, which needs 8 grams or 6 grams a day. They won't be able to achieve the continuous infusion with that, but they may do the prolonged infusion. Tazocin, I think, is less of an issue in this perspective. The other thing is the patient who's on renal replacement therapy initially has been excluded from this trial, which is a large cohort of patients that we usually see in ICU with sepsis. So the efficacy of that might be questionable in this cohort of patients.
Fair enough.
Mhm.
Kevin, did you have anything to add?
I think that was a pretty good summary. The one thing I would mention is the meta-analysis doesn't differentiate between continuous and intermittent infusions. So the meta-analysis showed the most potential benefit, but it doesn't tell you whether intermittent or continuous is better. So we don't know the answer to that question still. The BLING-III trials of continuous didn't really come out with a clear answer. So it's the question is, I don't think the question is whether we switch. The question is how we switch. So the easier switch practically would be intermittent, especially with the stability of meropenem. You could do prolonged infusions for meropenem and tazocin relatively easily. Continuous would probably require more of a guideline. There may be issues with ward transfers and IV lines being taken up. So I think that's a question for core and QNS locally for us to agree what we want to do. So yeah, I think we should move forward with it. It's just how we do it. I think it's the question really.
Yeah, I think we do need to change somehow. Maybe clever people like Kevin can figure it out.
Yeah, no, I think Piyush is working on it at the moment. So hopefully we'll have something to bring to one of the ITAPS groups. We can get going with it.
Awesome. Hopefully that will be a plan then. Cool, thanks Kevin. I stuck up the feedback link so that people can get certificates if they would like. Thank you, Mohammed, for doing that.
Thank you.
Very helpful. Well presented, thank you. And teaching next week is Dr. Anna Manami doing one on novel cardiac medications next week. And Spice is going to do Janicum.
Yeah.
Cool. Thanks, guys. Have a lovely
Thank
weekend.
you. Thanks.